Okay, we'll get started shortly. Attendees are joining us just now as we broadcast. Welcome everyone. Good morning, good afternoon, and good evening for some, depending on where you are. I'm proud to present today on behalf of the Association of Academic Health Centers International, our live MENA webinar on online teaching and faculty development. Our moderator for today will be introducing our panelists who will present on this topic, and she will present as well. I'm pleased to present Dr. Iman Hakim. She is the Dean of the Mel and Enid Zuckerman Endowed Chair in Public Health and the founding director of the Global Health Institute at the University of Arizona in the United States. She holds joint appointments in the departments of Nutritional Sciences and Family and Community Medicine. She earned her medical degree from Cairo University, Egypt, where she completed her pediatric residency. She received her PhD from Ain Shams University in Egypt and her Master in Public Health from the University of Arizona. Dr. Hakim, the floor is yours.
Thank you very much, Habiba, and thank you all of you for joining us for this webinar. It is my pleasure to be your moderator today, and I will present the first topic, which will be related to the education plans and faculty development post-COVID-19, and it will be my pleasure to introduce all the panelists. So allow me to share my screen. And so, as you know, I am the Dean of the College of Public Health at the University of Arizona, and as such, we are leading the whole re-entry plan, developing the instruction modalities for which we will be teaching this semester, and I will be sharing with you some of this information. So the first thing, as you all worldwide have experienced, it's in March. It was around spring break when the decision was made due to COVID-19 that it would be much more safer for students and faculty to turn to online education. It was a quick and abrupt decision just following spring break. We were fortunate enough that we do have a fully functioning online programs. The university has an online programs, and the majority of the faculty have their material on D2L, which is the platform we use, which is Desire to Learn. However, it was not that easy because they needed some support, some work to make sure that we go through the semester. Then forwarding through, we realize that it is not the ending, as you all know, and we have to make the tough decision about online education, hybrid education, reopening the campus or not, as well as what faculty support and development need to be put in place to allow this transition. And going forward as well, we are thinking what will be post-COVID-19. So I will share with you in a few minutes what we have done so far. So to support the faculty and for them to be safely teaching, we have done a lot of training for them, how to use the flipped classroom, how to use D2L, and we divided our support into 3 different areas. One of them is related to the facilities itself, the classroom in which they will be teaching. So we have done reconfiguration on all of the classroom. So the classroom that will fit 100 students will now only house 40 or 30. We have did a whole reconfiguration to allow at least 6 feet social distancing in each direction. So we blocked some of the chair and the desk. We also put hand sanitizer everywhere, all the station. We put plexiglass for all of the instructor if they will be teaching face to face, all of the offices where there is a receptionist, and we put touchless paper towel dispenser and the disposable mask in case somebody will show up without a mask. Then there will be no excuse. We will be have masking to deliver to the student. Then when it comes to the faculty support itself, we are using Zoom mainly for the teaching during that epidemic and now. And so we have provided technical support for Zoom, both at the college level and at the university level. This included training, included provided student support and GRA and IT to be ready for the faculty to be able to deliver their material. The Office of Digital Learning within the university provided a lot of support to help configure how to use a different chat room, how to use breakout room, and how to put the format for those who don't have it in a completely online format. In the same time, we understand that it challenges. So we have discussed, developed, and now we are implemented flexible teaching modalities that can be fitting for the need for each particular faculty based on age, based on children at home, school is not starting. And also we have developed a Zoom room within the colleges in which the faculty can be coming, do the classroom, even in isolation, having the Zoom ready technical support for them so they can be kind of interacting, but in a safe place. And that will be automatically recording for the I-course. So for the different instruction modality, what we have done is we have 4 modalities, and one it's called in person, one is flex in person, one is live online, and one is I-course. And the difference between them, then with the in-person modality, the student and the instructor will be all attending class in person, but with enhanced physical distancing and cleaning protocol. We have actually in some areas of the campus, we have put outdoor tent with cooling. So if someone a breakup room, they could be attending into the outdoor. And so all the classes required enhanced protection, sanitation before and after. So it's a lot of work. We require face covering for instructor and student. It is mandated. Now it is in all the syllabi. The disinfected for the student to clean their individual space coming in addition to the big dispenser, they will always have individual one that will be handed so they can clean their space when they arrive and when they leave. We have done increased airflow. All of the ACs have been checked, and class move into larger classroom for physical distancing. And the big classroom have been divided into small groups. The flex in-person courses, and that's much more of the number than the complete in-person for right now. And in these courses, the student will participate in a mix of person and online modality. For example, the instructor may divide the class into rotating group that alternate between in-person and online following the weekly class schedule, or the instructor may divide the class into separate in-person and online groups on a rotating basis. They will then lead the course for student in person in a separate time for the remainder of the class. And our Associate Dean of Academic Affairs for all of the faculty who are teaching in this fall have met with one-on-one to adjust the situation for their own comfort, for their own safety, and to make sure that we accommodate all of their needs and to make it safe for everybody. The live online, this is similar to what happened in the spring, but it's much more in depth and sophisticated. which basically the instructor and the student are online simultaneously. And for this one, they can be teaching from their office if they want to, from home if they have the capacity, or from a Zoom room. And the instructor will provide the content via Zoom, Connect or Google. We are mainly, most of them in our specific college are using Zoom. And then the live online courses are a good option for students who are planned to engage remotely for the duration of the semester. And some of them might be in the dorm, but they decided they want to be online for their classrooms. Then all of the courses will be available as an I-course. And in the I-course, the student and the instructor are not be required to be available simultaneously. So it is mainly an asynchronous course. And so the student complete their work independently through the platform which we use, which is D2L or Desire to Learn. Like live online courses, these I-courses are very good option if the students are planning to remain remote for the duration of the semester. And the students have this option. They can come to campus or they can study remotely from wherever they are within Arizona nationally or globally. And so this is what the brochure and what we have on our website and the university and the flyer that went to all of the students and all of the faculty to give a visual about what is a guide for the in-person and online courses. And as I told you that the in-person, flex in-person, live online, or the I-course. In addition, knowing that faculty are coming and students, we have employed the 3T, TTT, which is test, trace, and treat. And we were able to do so because we were able to develop the testing on site. So it became much more cost effective. And what we are doing is we are testing all the students who are in the dorm. Students who are out of the dorm are very highly recommended to be tested. And all of the faculty going back to campus are highly recommended to be tested. And the main idea is we need to have the prevalence, people coming back, so we will be able to capture any outbreak that goes on. So these are the testing, and we are testing all asymptomatic student and employee. Of course, if somebody has symptoms, the strict recommendation is stay home and be isolated. So antibody testing, we are running as an IRB approved research study. It is involuntary for all faculty, basically testing to the antibody to see if they have any level of immunity. And that will be kind of a research study doing a follow-up to see how long also it will last, so it help in planning for the future. But the main one is the diagnostic testing for the campus reentry. This is mandatory for all students in the dorm, as I told you. It is highly recommended but voluntary for the students who live off campus, and also voluntary for tests for all employees. As far as yesterday, 5,000 students, we are bringing the student to the dorm in groups. So within the 5,000 students that have been tested, we have 28 antigen positive who completely asymptomatic. So they are in isolation. They are not happy, of course, undergraduate students feel healthy, but we do have a plan to isolate up to 600 if something happens, and we are watching these very carefully. And then we will do surveillance testing, which will be a random sampling with PCR test to establish a prevalence, and our goal to look for 800 students and around 800 employees. And we are wondering and looking for a hotspot and spike, specifically in fraternity and the houses where students congregate over the weekend, and having some socialization with no social distance, and to be capture any rise a case or two to make sure that we follow up a procedure for isolation and notification. So what we are doing to support both, we call it state launch for in-person instruction on our campuses. So what we are doing right now is we only allowed on campus and face-to-face what we call essential courses. This will be lab related, that may need to be medical student, nursing student, those who in the arts, whoever need this physical presence, they are the first one that launched on Monday. We are watching on a weekly basis. So like our plan was to launch the second stage next Monday. We postpone it for another week. And the plan is the next stage will be entering student for small classes, 30 or less, and then watch it and then go for the full classes. So we decided, giving our number, thankfully, are going down within Arizona after a high spike in July. However, and we want to watch what happened during last weekend, the first weekend that they were here. And we want to make sure that we don't get the next group until everything is looking good. And we decided that we will not the date to set when we move, but actually the actual data that we can find, and our student and faculty feel comfortable with this approach. So we are monitoring, as we said, the number of new cases. We're monitoring new condition. We shift between the stages. We are providing continuing training for the faculty, providing a GRA or support and IT support available for them to help with anything they need, and extra support for the breakup courses. And the website about the COVID and about what's happening on campus is updated daily for all of them. And with this, this is our pledge that we give to our students. That's myself and my fellow Dean of College of Pharmacy. So we are doing a campaign to make sure that all of the student, faculty, and staff pledge to have masks and to experience social distancing. So with this, I would like to thank you, and it is my pleasure to introduce our second speaker. So it's my pleasure to introduce Chancellor and Professor Hossam Hamdi. And Professor Hossam Hamdi is Professor of Surgery and Medical Education and the Chancellor of the Gulf Medical University in United Arab Emirates. He is an internationally known medical educator. He has introduced several innovations in medical education and has been involved in the development of several medical schools in the MENA region. He won the Sheikh Khalifa Award for the Distinguished University Professor and decorated by France for his academic achievement as Chevalier dans l'Ordre des Palmes Académiques. So please welcome Dr. Hossam Hamdi.
Thank you, Dr. Iman, and it's a pleasure to be with you today and seeing my friends and share with you some of our experiences during the fast movement to distance learning and online learning, which took place over the last few months, and its implication on the post-COVID, or the first phase of the post-COVID education, higher education. I'm very also honored that we have a very close relation with the University of Arizona, and we have learned a lot from what they have been doing. As my presentation, the outline of my presentation, actually, I'm not going to focus much on the health and safety procedures and all what we are going to do, because there will be big similarities between the different universities and different institutions. In addition, that the Ministry of Education and Ministry of Health has provided us with very strict policy and procedures which we have to follow it up. It has, of course, many of the issues mentioned in Professor Iman's presentation. But I want to focus more on the lesson learned when we moved to the full online during the peak of the COVID, how this, from an organizational perspective, the technology the students, faculty, the learning resources and simulation assessment, and the implication of that on accreditation, and how we are going to function from an academic perspective after 1 week when we start in September, educating our students in what they call it the new norm. Of course, I have to say that our university is a medical university, which means that all our courses, all our colleges are in the field of health professional education, which gives us a sort of a peculiar situation than a general university or a comprehensive university. Let me start. I was really interested seeing this, which has been described by French philosopher Alain Badiou, about what's an event, which has the power to rupture standard practice and approve knowledge, disclosing heightened ability to think and act. I think it applies quite well into what is happening due to the COVID-19, although it was not put at that time in relation to COVID. I will start one of the first lessons about when we, in 1 week, we've had to move as an organization to distance learning. It was very important to start first of having and developing a task force which would be responsible for this transformation. And because the task force had champions who are either technology experts, while academic, in the meantime, they are academically involved in the courses at the university. And this task force has led this transformation and was very successful. Part of this was the use of the multiple technology platforms, which either existed in our university or we had to subscribe to it or join it or to access it. So our learning management system is Moodle, but there were others like the Google Classroom and the Microsoft Teams. And the same applied to the video conferencing solution, which existed in the university, and we were used to it, like GoToWebinar and GoToMeeting. Zoom, we were not using it to that extent because it was not open as before, and while the others, the Google Meet and Teams. The problem here is that having all these platforms, technology systems, and we can have a problem if we keep moving between them, and it's important to limit the platforms in order to optimize its capability. Faculty and students and the technological support should limit the number of these platforms so we can really benefit from it. Otherwise, it will be difficult, and many issues came up when we started using more than one platform. Concerning the faculty, which I think Professor Iman has alluded at it, training. This was very important, training the faculty on how to transform the face-to-face to distance learning, which is really challenging. It's not that easy. And of course, training them on these different platforms. So our academic IT faculty were able to lead this and continuing providing training. It was important by the faculty to adjust their study plans and make changes, whether in the timing or the content, and this has to be also done very quickly. The educational approaches, as again indicated by Dr. Iman, being synchronous and asynchronous. And here I would like to maybe to spend a few minutes on that. In the synchronous, using online communication tools, we have used GoToWebinar, and we found that it was preferred by faculty and by the students because it was easy to transform the traditional classroom lecture to a digital environment. They can upload their slides and they can keep talking and they can use their PowerPoint voice over PowerPoint. So it was not far from what they used to do sometimes in a traditional classroom. So, but it has a low educational impact because the degree of students' engagement usually is limited. Yes, they can ask questions, but we have noticed that the students keep quiet while the faculty is presenting. So we have found that it is more of a teacher-centered approach. For the asynchronous, it definitely has a high educational impact, and it is more student-centered because it required active engagement and providing continuous feedback, whether and how to do that in structuring the lesson plans. It needs experience, it needs faculty development, it needs technical supports, sometimes what they call them instructional developer or content developer, to include different assignments, activities within the lesson, and that's not easy. So for example, this is a flow chart which we have developed for the asynchronous online lesson plans, how we start by the objectives, the content, the activities, the timing, the feedback which has to be given, then coming back, report the cycle to cover all the objectives has been covered or not. So it needs effort in order to do that, and we are continuing transforming many of the faculty lesson plans into this flow chart. The learning resources, there are many and multiple learning resources. They are available open resources, but faculty needs to review and select the appropriate one for their course because there are too many available now online. But it's the faculty role is try to identify what will fit more with their courses. The closed resources, we have used this Scholar X, the BRICS. We have found it a good fit for us. I think it is used by several universities in the United States at the moment, and maybe another time we can talk more about it. What we are proud to mention that we have developed here in GMU over the last 4 years using artificial intelligence, what we call the virtual patient learning, which is a high fidelity simulation system where the learner plays the role of a physician who confronts an authentic simulated patient. So it's not a cartoon or an avatar, but it's actually an actor, so it's a human being. So the fidelity, particularly the psychological fidelity, is high. And the interview with the patient can be paused at any point for discussion and for generating learning objectives and interaction with the PBL tutorial, because we are using it mainly for the problem-based learning, which is one of the main strategies of learning in our university, not only in the medical school, but in nursing, in pharmacy, in physiotherapy. And feedback, of course, is given by the patient at the end of the encounter, whether using a telephone call, and the patient share their impression on the meeting with the doctor, which here is the students. So this is the library, we have it, which covers several, practically all the systems of the body. We have at least 2 or 3 patients, simulated patients in relation to that. So it was very useful to continue using it and conduct the PBL online. Next. Just to show you a quick. And he can examine the patient, vital sign, order investigations, and so on. Next. Even video of a colonoscopy. This patient, for example, has cancer colon. Stop. So just to give you an idea of what we mean by virtual patient learning. So we have used this regular PBL small group. The PBL small group were maintained online. Tutor and students communication and discussing using video conferencing. So for the first time to conduct this PBL from a distance. And the weekly PBL tutorials, the resources and review sessions were conducted also online. It was the students were highly satisfied, and we have indicated, we've done a survey about that. Going back to the students, although they are very good in technology, but actually they need training and some behavioral changing for using it when it comes to education and their studies in universities. And we have to look into that. On the other hand, they adapted quickly to these new approaches and were happy in all the surveys we have conducted, generally happy about their learning. But the students, they need technical support and academic support. We have a strong mentorship program, so practically each student is supervised by a mentor. And this has to continue after the re-entry in September. Now coming to assessment, which was a challenge. If we are talking about giving MCQ exams online, this is nothing new in that. I mean, this is easy done and to be easily corrected. What we have created as innovation is about assessment of clinical competency. And having the virtual patient, we were able to develop a virtual clinical encounter examination, what we call VICE. Next. And so as you can see here, there is interaction. We were able to interact with the students. The students will interact with the virtual patients. You can see in the screen when the students were taking their exam, and in another screen, the faculty control room observing what is happening. Perhaps in another meeting, I can report more about the study and validity and reliability of these instruments. Next. We have used faculty as simulated patient, and because particularly the reasoning process and the decision-making process needs much more than just a non-medical or non-health profession simulated patient who can judge the sensitivity and specificity of the questions with the question which the students are asking to simulate the patient. Next. So when you come up to this, what I call the messy world of proctoring, because this was an issue when conducting this exam online. And too many efforts and costs were put into that, in my opinion, with little rewards. The internet connectivity, the IT infrastructure and use device can cause a lot of interruption when we are using this proctoring. The different instruments to prevent cheating has limited value. We have used some of the system where they give you a report after the exam. So we must have a new look into what is academic integrity and cheating behavior. And we have an ongoing research at present on these issues. So what's next? Of course, what's going to happen starting next week, we are prepared to have the safe educational environment. The technology we are now experienced in using what will fit with our program and facilities. We are using more simulation and resources, particularly in the practical and laboratory and some of the clinical aspects. The continuous training of the faculty and students on the distance and face-to-face in this. We are going to increase the early clinical exposure of the students in our hospitals, because we have found that the students, they have played a very important role during the COVID lockdown, and their effort was highly appreciated by the hospitals. We will be conducting and still doing more assessment online and more EPBLs. Research of this area, research-driven evaluation of this new learning environment is important. We believe that the regulatory bodies and the accreditation, they will play an important role in driving the evolution of what we call distributed learning, which will combine fusional and different blended type of learning. So thank you very much, and I'm very pleased to be with you today.
Thank you, Professor Hamdi. And now it is my pleasure to introduce our next speaker, Dr. Rumeysa Kazansioglu, who is the rector of the Bezmialem Vakif University. She is also a professor of nephrology at the university with over 10 years of experience and a previous vice dean of the Faculty of Medicine. She is a graduate of Istanbul University. Dr. Kazansioglu research area of interest include medicine, health science, internal medicine sciences, and nephrology. She has more than 150 articles published in journals, including in Science Citation Index, Social Science Citation Index, Arts and Humanities Citation Index. Dr. Kazansioglu has attended several teaching courses by Erasmus program in the last year. Please, Dr. Kazansioglu, you have the floor.
Thank you, everyone, for including me for this talk. And I would like to share with you our experiences during this COVID pandemic, what we experienced during the last term, actually. And I would like to give you an overview of what we received as national advices from the Council of Higher Education and what our experience in Bezmialem were. And actually, I'll just give this brief table about the numbers, because we were very hopeful by the end of the last term that we might not be having that many patients, COVID patients in the university hospital for the next term. But it seems that for the last week, we have an increasing number of patients. So our strategy is to reopen the university at the beginning of October was the right decision when we got together. As Professor Hamdi was talking about, our university is also a health sciences based university, a small university with less number of students than any one of you actually. And since last March, with the pandemic also affected our education system, the higher education system, and we had to take many measures to make sure that we could continue our education and keep our students and as well as our faculty safe and get adapted to this new system actually. Well, we had our first case in the beginning of March, right before the declaration of this disease as a pandemic. And what we did as higher education on March 13, actually we had suspension of all education and internship activities in the university for 3 weeks at first. Then later it was postponed to further months during the term, and we had to come up with a strategy to keep the work that we had decided to fulfill for our students, health science students. And also the public places were closed. So in those universities where the dorms were occupied, they have to evacuate all their students, send them away. Our disadvantage as a university not having a dorm actually turned out to be advantage for us for this term actually. And after these 3 first weeks of stopping the educational activities, we have to resume the online education. But of course, our students could not be involved in the clinical education. And actually, there was a survey among our last year students, the 6-year students, which we call interns, among the many of the medical schools in Turkey. And most of the students actually refused to be participating in the internship program, and we had to postpone it for a while. This is from the first paper that we wrote about our experiences by Ismailem. And before the pandemic, the distance education was a part of our education system, but it was not fully implemented by all faculty. So we had to come up with this asynchronous and synchronous education models for our theoretical lessons as soon as possible during this 3-week period that we didn't have the students on board. And we had to also upload some videos about the skills and the practices that we promised to teach them during the term, be it the previous years for medical school students or the nursing students or the physiotherapy students. And but it was still impossible to replace the formal education that we were used to till now. What we did at first, we came up with the synchronous or asynchronous training, and we used our educational technical infrastructure to post these lectures online for our students. And what we needed, we had to make sure that every student had access to information technologies. It might not be a problem in the States or in the Gulf region, but we realized that after 2 days' time that not all of our students had the enough resources to access the information technologies where they are based, because they were out of the university campuses, they were living with their families, they were back to their towns and etc. And we have to improve the skills of our instructors very soon to make sure that they complied with the new requirements of the teaching technologies that we had to deliver. But we realized that there was no problem in the implementation and the maintenance of the theoretical lessons, because some of the faculty actually were very well involved in giving the lectures online or distance learning. Some of the faculty, of course, embraced online education because some of the faculty were also sent home because of the age restrictions, because of health restrictions. They had to stay at home and work from home. So they embraced this type of education. But some of us, the old classical way of teachers or instructors, we had to adapt to this new way of technology, and we had to integrate the available resources to continue our education, and we had to be fast to change into this online education than to face-to-face classical trainers. But of course, to do that education or training of the faculty or education of the trainers, educators, instructors, we had to give them quick online courses or teachings or some peer reviews with the how to use the technologies or upgrade their computers at home, and to make sure that they participated in the teaching events. And we got the help of our IT department. I'm grateful to that team and our administrative office workers. They were great in helping the faculty, and also they were helpful in managing the student problems to get into the lecture rooms and the halls to use the sites and the resources available. What we did was we had a dedicated staff member from the IT division, and they had individual consultations with the faculty. They had these online interaction with the faculty to make sure that everyone understood what they were supposed to be doing in this type of distance learning. Then we had the individual consultation with the peers, with seniors talking to the juniors, actually sometimes junior faculty talking to the seniors to make sure that they understand the importance of distance learning. And there was a university-wide training, which was mainly online training. And we had the technology mentors, which were who were kept in the campus. And we placed some different stations in the campus with the computers or the assisted material available for those faculty who are willing to join us in the campus, of course, with all the precautions taken, because we were declared as a pandemic hospital and the hospital is in the campus. So we had to be careful about that. And we made sure that at least 10 hours of training, online training, tutorial were given to each of our faculty. On top of that, the Council of Higher Education also provided some resources for faculty training, and we were given freedom to join some of the formal online courses to move forward to get some certificates on online teaching, actually. What we used as the infrastructure, as Professor Hassan was talking about, we used learned based infrastructure. It was a Moodle infrastructure that we had for teaching facilities in the university. And all the lectures had been introduced to the system. And the other thing was that we had to deal was, we had to adjust each lecture to the related students so that they could be in the classrooms that are dedicated to themselves. Otherwise, they would mix the nursing students with the medical students as well. So they could log into this system via their passwords that have been issued to them to use the student information system. They could use it. And the iSpring and the PowerPoint presentations were uploaded for the asynchronous teaching methods. And then also the open resources were also used after the approval. This was put onto the whole student information system available for all our students. And I'm thankful to the library of the university as well. They were very helpful in finding out open resources or webinars or all kinds of teaching material that will help our students and faculty as well. And then we also used Moodle and Adobe Connect for the synchronous lectures at that time. Couple of numbers about how we did between March and June, and we had documented all the duration of the lectures and the number of the lectures. And as I was touching upon, we realized that internet services were not free for some of the students. So Higher Council of Education actually came up with providing free internet to our students, all of the students in the country. So we didn't have any more issues related to that in a month's time. So with the School of Medicine, we nearly had all of our lectures posted on the system, and the mean class participation, though at some weeks it was lower because we had other things going on during that time, we had a good participation for all of the lectures. It was not same for the School of Dentistry. They were a little bit disappointed because their hands-on courses or their clinical attachments were important and they couldn't get to that at that point, which was actually fulfilled during the summertime with the organization of the School of Dentistry. They could do their missed times during this period actually. And this is what the health sciences, the nursing school, and the physiotherapists and the dietitians, they were more eager to be in their lectures and they participated. And we also did a survey among our students to see if they were happy about the type of teaching that we provided to them during this pandemic time. And we came back of this result as they were 84% of the students participating in the survey were happy with the way that we were trying to provide the education. And of course, the prep school, in part of the curriculum, we have 30% taught in English. So it's some necessity for our students to be competent in English. So we have this prep school, and they were probably the most ready ones to go on with the synchronous teaching, because most of their program included web teaching, online teaching. So right from the beginning, they were giving their lectures synchronously, and they were performing their assessments, their exams online. And these are the numbers that we have put onto our portals, all the PowerPoint slides or the videos that we uploaded to the system. And nearly all of the students, my number of students is 3,000 altogether, including the postgraduate school, were involved in this kind of teaching. But what's going to happen for the next year, for the new term? Actually, only the interns have started since last month, and it's a class of 100 students. They are there in the hospital with all the courses that have been given to them with how to take precautions against COVID-19 and how to do all the screening and etc. But we're aware that as in the universe, we have to have this mixed form of education in schools of health sciences as well. And we have this new normalization guide in global pandemics set by the Council of Higher Education, and there are topics, and it has been issued to all of the universities, but mainly it has been left to the running of the universities and how we want to organize our programs. So we are planning and implementing using this mixed type of education where we're going to use all the online resources, distance learning resources, and we have actually improved our infrastructure, and we're going to use Microsoft Teams. And currently, actually, some of the faculty are receiving their online courses, how to use this new program for this year. And in short, the COVID is here to stay for a while. We have taken our standard precautions to take care of our healthcare, but we also have to keep in mind that the education has evolved into another stage, and we have to implement these new normals to our education strategies for our students and our faculty as well. And here I stop, and thank you for your interest.
Thank you very much, Dr. Kazansioglu. And now it is my pleasure to introduce Professor Ibrahim Janahi. Professor Ibrahim Janahi is the Chair of Medical Education, designated institutional official, and the Division Chief of Pulmonology at Cedra Medicine. In addition to his current responsibility at Cedra Medicine, Professor Janahi is a professor of clinical pediatrics at the Weill Cornell Medicine in Qatar. He is the founder and president of the Gulf Society for Pediatric Respirology and the founding member of the Arab Pediatric Pulmonology Association. He completed his pediatric residency at University of Illinois College of Medicine in Peoria, Illinois, United States of America in 1997, after which he started his postdoctoral fellowship in pediatric pulmonology at Baylor College of Medicine in the Texas Children's Hospital in Houston, Texas at the USA. Welcome, Dr. Janahi, you have the floor.
Thank you so much, Dr. Iman, and thank you all for being part of this. And first of all, thank you, AAHC, for hosting this very important panel. Unlike my colleagues, senior colleagues who brought in very interesting slides and some good information, what I prepared is myself. I don't have any slides. So I'm just gonna highlight a few things that might be of interest for the audience with regards to doing medical education and education in general in a hospital setting. Here at Cedra Medicine, let me just give a little bit of a background around Cedra Medicine. So Sidra Medicine is a women's and children's hospital, a tertiary hospital. It's a state-of-the-art building and system. It is supposed to be an all-electronic system, i.e. Not much, really almost close to zero paperwork. And therefore, this is a good segue towards what I wanted to highlight is that the Sidra medicine system itself was in a position, in a fairly good position to adapt to any online or an electronic system of education provision. So Sidra Medicine as a hospital is a host for undergraduate students from Weill Cornell Medical College, as well as from the Qatar University National Medical College. In addition to having a very wide array of postgraduate program, we are the host of the main or the only pediatric residency in Qatar, in collaboration with our colleagues at the other hospital, Hamad Medical Corporation. In addition to that, we provide a range of subspecialty training in different medical, surgical, and support pediatric training. So we do have all the different subspecialties in pediatric medicine, most and probably all the surgical subspecialties in pediatric surgery, as well as pediatric anesthesia, pediatric radiology, pathology, psychiatry, and toxicology. These are all postgraduate programs, that residencies and fellowships, in addition to a very robust CME CPD program that has been ongoing, and we provide anywhere between 160 to 180 CME programs per annum. Now, this hospital is a rather new hospital. We started operational, our outpatient operation sometimes about 4 years back, and our inpatient started in 2018. So we are now fully operational, and from the get-go, this hospital was built as an academical system to host education, and there is also a very robust research program that goes on as well. So that's just an introduction of what we do here at Sidra. What was going on before COVID was basically all the training was happening here, right in the building. There was very few activities that was going on as far as teaching is concerned online. Although the platform was always available, but the utility of these platforms were really not, were very low. Now with COVID coming on board, as far as the platform and availability of these platforms, where the utility of it, right, jumped up by more than 80 to 100%, and most of the lecturing and the direct teaching started happening online. Using the main platform that we use is MS Microsoft Teams, but also Zoom is available, and some other platforms are also available if the provider prefers a different platform than the MS Teams. Now, in addition to that, obviously during the active period of COVID activity and the number of cases being high and all that, everything was online. People were not allowed to come to do physical teaching in the building. In addition to this hospital being designated as COVID-free hospital, which has its own implication of not allowing anybody who is not tested or who tests positive into the building. And that there was a very strict, rather, mechanism of not allowing anybody who is a potential for COVID to come into the building, and therefore that casted an even more challenging situation to trying to do some of the more of hands-on training. Those hands-on training include clinics, inpatient, and simulation. The clinics were all transformed into virtual clinics. So they were provided online with the patients, and there was the option of either telephone or video or both. And the students were kept away from this experience, except if they are willing to join in from their homes, and at that stage there was a requirement for them to be trained and consenting and so on, because of the patient confidentiality and so on. The inpatient rotations were also modified in a way that would minimize the number of people who are physically in the building, and therefore these medical residents and students were not able to come physically into the hospital. For the compensating that, there was online modules that were made available for them. As far as the simulation of life support courses and simulated courses, they were all also put on hold during the active period of COVID, and this was stage 2 and stage 3 and stage 4. Stage 3 and stage 4, where the numbers were close to 1,000 or above 1,000, and then once the numbers started going down, we went into the more opening up the country, and this was always managed by the central command center of the National Command Center. So CIDRA would adapt to whatever the direction is as far as the number of people allowed in a given time in a building or in a room, and keeping the social distance, using the PPEs and so on. All that have been adopted as per the standard that were basically published online. Now, as we move on, we've now reopened, and we started bringing people back into the building, and the residents and fellows and the students are starting to come back to the building. The program is starting to go back to the hybrid physical online. With this experience of trying online platforms and working out the glitches that obviously happens with any online system that you would use, those were all worked out throughout the period where this was all online. And now we know what works and what doesn't work, and that has been actually integrated into the curriculum of both undergraduate as well as graduate programs. So now we have hybrid system that is working pretty well. And I think that the lessons learned from the couple of months of lockdown, a couple of months of all online, has helped immensely in reshaping the curriculum as far as the clinical teaching is concerned, in a way that would be more productive, more time efficient, more resource efficient, I would say, human resource efficient. So all that is good news. The challenge is obviously that you aren't sure whether people who are online, the learners who are online, are actually really online and interacting, and that piece of interaction is distance, and that brings in some challenges. And I think that the second biggest challenge is that people aren't used to delivering curricula based on these new technologies, and it will take few I would say years until this becomes part of the DNA of medical education. We aren't there yet, but this lesson of going through this actual forced on experience is very, very helpful in trying to shape the new curriculum, the new generation of educators and learners. I think the young generation has adopted to this much quicker, obviously, given the fact that they are more savvy with technology. The educator our generation and the generation before us, which are basically leading on education structures, education curricula, I think we ought to start to become more flexible towards adopting these new technologies as part of the new quote-unquote norm. I'm trying to just put some highlights only, and most of the details are pretty much the same as many other places, and it has been already highlighted by the previous two eminent speakers and by Dr. Iman as well. So we did pretty much the same thing, maintaining all the protocols, maintaining the distance, social distance, PPEs, having the backup IT support, making sure that people are trained properly. There are online training of these platforms and so on and so forth. All those are pretty much the same. So I'm going to stop in here and basically allow people to interact and ask any questions that if they might have.
Video. Can I?
Okay, start my video. Okay, thank you very much, Dr. Janani. And I will start to have a question to all of the speakers based on your different experience. And my question is post-COVID-19, how do you envision the role of online teaching at your own institution and within the region? Because there was a lot of challenges with online, with some countries adopting it, some refusing it. So now that everybody experiencing it, what you envision in your own institution, the online, and whether synchronous and asynchronous will go post-COVID-19? And I'd like to hear from each one of you.
I can.
Dr. Hassan, we can, yeah, please go.
I think it will continue. The educational environment has been transformed, and it will continue to be transformed to the better. I think this is one perhaps of the advantages of this event, which of the COVID, because what would have taken maybe years, many universities were able to do it in a few weeks. So this is one point. I've mentioned the word distributed learning because learning is different from teaching. So any good learning, we should use multiple and different modalities to achieve the behavioral changes, if this is what we are going to do. So in our experience, what has happened is we have noticed that faculty were more using more the synchronous, while I was pushing more toward the asynchronous. But the asynchronous needs training, and it's more difficult because it needs engagement and it needs feedback, and it put a lot of effort on the faculty. But we are keeping pressing in this direction. In addition, the combination between the practical and in our situation and similar situations in the medical universities, the clinical environment. This will not be affected, and I think maybe it will increase. We have noticed that what we keep talking about interprofessional education, it was a fantastic opportunity for medical students, nursing students, pharmacy students in the hospital. They have been working together and learning together. So there will be many changes which are going to happen. And actually, we are bringing more early clinical exposure than it used to be. The classroom, the face-to-face component of the teaching is not going to be to give the lecture. The lecture, as you have mentioned, either using team-based learning or flipped classroom or something, it can be given to the students while they're maximizing the value of being in the classroom for other important things, for discussion, for concept clarification, more interactive than just the delivery of the lecture. So all these different modalities and distributed learning will continue, plus the assessment also we're going to change, and we can talk about that in another presentation.
Great. How about in Turkey?
Okay, well, I completely agree with Professor Hamdi that this disaster or pandemic actually caused us to learn these things in a faster way, which would taken us probably at least a year to sort of put on the synchronous teaching or the asynchronous teaching. And I completely agree with the asynchronous lectures takes more time and dedication, and it has to be more refined. But going through this experience, actually, we realized that there was a topic that one of you actually touched upon, that the contribution of the students, because they're not seeing us or being with us face to face in the classroom, they are more reluctant to ask questions. But in fact, it was the otherwise. Looking into our students, we found out that many of them preferred to write down their questions rather than coming up in the classroom and asking some questions and being sort of ashamed of not knowing or recognizing the principles of those topics that we're talking about. So we had more interaction with the students than we expected, and we are trying to come up with ways to improve that. And of course, with the clinical teaching, with all the healthcare students, health sciences students, we will still have them on site with all the precautions taken, because this is a great opportunity for them to get prepared for future disasters, pandemics, or whatever you call, looking into our region, what happened lately in one of our neighboring countries and what you need to be dealing as a healthcare provider. So I think it's a good opportunity to be able to continue the online education, distance education, both for the students and the faculty. I also have some concerns with the assessments, and that's one of the topics that we need to improve for next term, definitely. We came up with all the measures that we could come up with, the ideas that the students will think about the cheating, and the integrity that Professor Hamdi was talking about is very critical. So that's another thing that we have to work on as well. Thank you.
So Dr. Janahi, in addition to the post-COVID, there is a question in the chat, might be relevant as well, which will be, what is the best way to carry out the bedside teaching for clinical medical students during COVID pandemic in an environment when there is no simulation labs, and how many students are allowed around the bedside of the patient?
Yeah, I mean, again, those are very, very good questions, and they're very practical. First of all, just a comment on the post-COVID era as far as the electronic resources. I personally strongly believe that it came to stay, and we are never going to go back again to the classic way of doing clinical teaching and so on. So this is going to come. This is here to stay. So we better, as an educator, adapt to it. Not only adapt to it, develop the new standards, especially when it comes to assessment, because pretty much all our assessment tools are not designed for this type of environment, this type of platforms. So I agree with my colleagues, the profs, that we ought to start focusing a lot on how to really come up with an assessment tool that would be as pristine as possible, as robust as possible, as practical as possible. That is very challenging. It's a question up in the air there at this point. Now back to the question in the chat. Yes, so the clinical teaching, bedside teaching, is pretty much limited to the size of the room, the number of people that can be in a given room. So this is like pure physics. I mean, you need to keep a meter and a half at least in between people, including the patient, and making sure that the PPEs are all available and properly worn, so that donning and doffing is properly done. In here at Sidra, we have a very I would say, advanced simulation system, simulation lab, a large one. So that is not, it's not casting too much of a challenge. We are able to provide the environment, the physical environment, to accommodate the number of students that needs to be in a given class. So the rooms are big and so on. But obviously, not all the other centers will have the same luxury of having big rooms, simulation, and so on and so forth. So I would say, to answer the question, is we ought to find a way to accommodate these people. You might need to have more faculty, more number of sessions, try to find other hospitals or other places that you can send the students to. We are not, I don't think we will have the luxury of having a whole bunch of people in one room anymore. And you know, some of the places that I've been examining at, they bring in like 10, 15 people around one patient in a small room. I don't think that would come back anymore.
Thank you. And we have a question in the chat for Dr. Hussam Hamdi. And the question is about distributed learning. The question is, it seemed to be appropriate during the pandemic, but what are the challenging for distributed learning, and can adaptive learning be a solution during the pandemic? You are muted.
I have responded to this question before. I don't think there is a big difference between adapted learning and distributed learning. It's just choosing the best approach of learning depending on the context, depending on what you want to achieve. So whether it is in a classroom or distance or in the hospital. I believe, but perhaps as distributed learning will be moving again between the skill lab is part of this distributing learning. But going back to the clinical issue, which was raised before, I think the key here is how to embed the students to become part of the team, which is in the hospital. So the traditional way, or one of the traditional ways of having more than one student around the bed, I think this will disappear because the issue here is based on the community of practitioner theory. Embed the learner in the work environment with the team, and they become part of the team, and learning will take place. So the traditional bedside teaching, which has always been changing, will change faster now. So I cannot imagine having 1.5 meters away from the patient and you want him to learn. It cannot happen. He has to touch the patient. I'm not taking, of course, we're not talking about being in a COVID hospital or directly with the COVID patients. There are different types of hospitals and where we can put the students. But again, it's an experience for them to be to see a patient with COVID and get closer, because it reminds me like someone who goes to the military school and he doesn't want to go for a war one day when it comes. So it cannot be like that. This is part of their professional development and their career, and they have to live this. And this is how clinical teaching has to change.
So Professor Kazantsioglu, do you have any other comment related to the clinical teaching simulation before and after COVID?
Well, I completely agree that we will not be having all of our students surrounding the patient in the room. We have just, decreased the number of available beds because of all the precautions to make sure that we are taking good care of our patients, even without the COVID. But now we have to make sure that they can be safe enough to touch the patients. I completely agree with that, but it's going to change definitely. And we will have to come up with brighter ideas to make sure that the students are in contact with the patients or patient caregivers or the relatives and other emergent situations as well. And the way that we're acting in the emergency rooms and those rotations have also changed. And we have put into our programs how to protect the students themselves from these kinds of diseases. It was in the curriculum previously, but it has now changed the form, and it has to be like a traditional way of acting in the clinics, as in the inpatient clinics and in outpatient clinics as well.
There is a question in the chat about, is any one of you have used the Cisco WebEx for any of the distance learning?
Yes. We did.
And if so, can you comment quickly on it?
Overall, it's pretty much the same as the others. It has its own limitations. In general, we didn't like it in this hospital. We went for the MS Teams for security reasons, that our IT security has recommended that. Zoom was the next option, and the last was the Cisco WebEx.
There is another question, I think, basic about what is the difference between synchronous and asynchronous teaching. So that's kind of the definition, if somebody want to clarify this to the audience.
Me? Okay. Well, simply synchronous is when the teacher and the students are communicating in real time together, whether online or even in the classroom, but this maybe it came up being online at the same time. Like now, we are in a synchronous mode. We are running this in a synchronous mode. The asynchronous is they can study, they can learn at any time, but they have the material which has been given to them or the lesson plan structured in a way to achieve the objectives of the session. So how to structure it from the beginning and how to insinuate within the lesson plan different activities, even if it is 1 hour. But let us say we're going to spend the first 5 minutes explaining the objective of this, and then it will be followed by 2, 3 questions, and then it will be by some PowerPoint presentation while the teacher has recorded a message, or to put some sort of resources, a video or a story. And it keeps going like that in a structured way, similar to a good lecture, which engages the students when they are doing it. So it needs effort from the faculty in its development and giving the feedback, whether immediately or later on after the students have gone through it. So I think are some of the main differences between synchronous and asynchronous.
Thank you very much to all of you. We are approaching the end of the webinar, and I would like to thank you, Professor Hamdi, Professor Kadancioglu, and Professor Janahi for participating today. I would also like to thank our staff from AAHCI, Habiba Osmani, and all of the audience for being with us. And thank you all. And I hope you all stay safe and well. Thank you.
Thank you.
Thank you very much. Bye.
Thank you.
Assalam.
Assalam.